Okay, let's unpack this. Today, we're taking a deep dive into testicular cancer, a topic that might seem daunting, but is incredibly important to understand. Our mission to sort of distill complex medical information into clear, actionable insights, straight from the latest sources like the American Cancer Society.
Exactly. And what's fascinating here is how much crucial information is available. We'll be breaking down what testicular cancer is, its different forms, how it's detected, treated, and what life looks like for survivors, all to help you feel well-informed without feeling overwhelmed.
Yeah, and you might be surprised by some of the statistics and the incredible progress in treatment. Whether you're curious, supporting someone, or just expanding your health knowledge, this deep dive is for you. So let's start at the very beginning. What exactly is testicular cancer?
Right. At its core, it's cancer that begins when cells in the testicles start to grow out of control.
And the testicles are the male reproductive organs, normally a little smaller than a golf ball, held in the scrotum.
Precisely. And understanding what they normally do helps a lot. They have two really vital functions, making male hormones like testosterone and producing sperm. The sperm production journey is quite complex, actually. They start in tiny tubes, mature, travel through various ducts, mix with fluids to make semen, and then eventually exit the body. Understanding these normal functions helps us grasp where problems can arise.
That makes sense. It raises an important question then. How common is this, and who is typically affected?
Good question. Well, it's actually not that common overall. For 2025, the American Cancer Society estimates around 9,720 new cases diagnosed in the U.S., and sadly about 600 deaths. So to put it in perspective, the lifetime risk for a male is about 1 in every 250.
Wow. Okay. And what's really striking is the average age of diagnosis, isn't it? Around 33?
Yes, exactly. It's largely a disease of young and middle-aged men, though, I mean, it can affect males of any age, older or younger.
But predominantly younger men.
Right. But if we connect this to the bigger picture, the positive outlook is key. The lifetime risk of dying from testicular cancer is very low, about 1 in 5,000. And that's largely thanks to really successful treatment, which is great news.
That is good news.
Yeah. And while the incidence rate has been increasing over the past few decades, mostly for seminomas, the rate of that increase seems to have slowed down recently.
Okay, so this brings up a really important point. Knowing the specific type of testicular cancer seems crucial, right? Because that affects treatment and prognosis.
Absolutely critical. More than 90% of these cancers are what we call germ cell tumors. They start in the cells that actually make sperm.
Germ cells. Got it.
And within those germ cell tumors, there are two main types: seminomas and non-seminomas. Seminomas, they tend to grow and spread more slowly. Most are classical seminomas, typically found in men aged 25 to 45. There's also a rare type called spermatocytic seminoma, usually in older men, average age around 65, and it's even slower growing, less likely to spread.
Okay, slower growing.
Right. And it's worth noting, some seminomas can increase levels of a blood tumor marker called HCG.
HCG. Okay. What about the other type, non-seminomas?
Non-seminomas. These usually occur a bit younger, maybe late teens to early 30s, and they tend to grow and spread more quickly. There are four main subtypes here. First, embryonal carcinoma, found in about 40% of tumors, though pure forms are rare. Grows rapidly, can spread, and often increases both AFP and HCG markers.
AFP and HCG.
Then there's yolk sac carcinoma. This is actually the most common type in young children. It's rare in its pure form in adults, but responds really well to chemotherapy. Almost always increases AFP.
Okay.
Third is choriocarcinoma. Very rare, very fast-growing in adults. It spreads rapidly, often to the lungs, bones, brain, and it significantly increases HCG.
Wow. Sounds aggressive.
It is. And finally, teratoma. These are interesting. They look like layers of a developing embryo under the microscope. Pure teratomas are rare and usually don't increase AFP or HCG. We classify them further into mature, immature, and teratomas with somatic malignancy based on how developed the cells look and their potential to spread.
There's quite a few subtypes. And you mentioned many cancers are actually mixed.
Yes, exactly. Many testicular tumors contain a mix of non-seminoma types, or even both seminoma and non-seminoma cells. And because the non-seminoma component tends to be faster growing, these mixed tumors are generally treated as if they were non-seminomas.
That makes sense. Treat for the more aggressive part.
Precisely. Now, beyond those main germ cell tumors, there are a few less common types worth mentioning quickly. One is carcinoma in situ, or CAS. These are abnormal cells just sitting in the tubules, not yet invasive cancer. Often no symptoms, found by chance, maybe during infertility tests.
So like pre-cancer.
Kind of, yeah. It doesn't always become invasive cancer, and sometimes doctors in the U.S. might just watch it carefully instead of immediate treatment. Then you have stromal tumors. These are rare, less than 5% in adults, maybe up to 20% in childhood cases. They start in the supportive tissues. Think Leydig cells, Sertoli cells.
Hmm.
They're usually benign, cured with surgery. But if they do spread, they often don't respond well to chemo or radiation, unfortunately.
Okay.
And lastly, secondary testicular cancers. These aren't cancers of the testicle, but cancers that started somewhere else, like lymphoma or leukemia, and spread to the testicle. Treatment follows the original cancer type.
Okay, this is where it gets really interesting for a lot of people. What makes someone more likely to develop testicular cancer? The risk factors.
Right. And the first thing to say is many guys diagnosed have no known risk factors, and most factors we do know about can't be changed, which makes prevention, difficult.
Yeah, that's tough. So what are the main ones?
Well, the biggest one is having an undescended testicle, condition called cryptorchidism, where one or both don't drop down properly before birth. That significantly increases the risk, even if it's surgically corrected later with something called an orchiopexy. And interestingly, the risk is slightly higher, even in the normally descended testicle for those men.
Wow, even in the other one.
Yeah. The exact impact of the surgery on cancer risk itself is a bit unclear, though the surgery has other important benefits.
Okay, what else?
Family history plays a role. Having a father or brother with it increases risk slightly, though most cases aren't hereditary. Certain genetic conditions like Klinefelter syndrome also raise risk. HIV infection, particularly having AIDS, seems to be linked to an increased risk too.
Hmm.
And as we mentioned, carcinoma in situ, that pre-cancer stage, is a risk factor for developing invasive cancer later. Also, having had cancer in one testicle means there's about a 3–4% chance of developing it in the other one down the line. Then there's age, race, ethnicity. We said average age is 33, peak between 20–34. Risk is higher for white men, American Indian, and Alaska Native men compared to others. And it's more common in the U.S. and Europe than Africa or Asia.
Any link to body size?
Some studies suggest maybe a slightly higher risk for taller men, but there's no clear link found with body weight itself.
Good to know. And just to clear up myths, things like getting hit there or horseback riding, no link, right?
Correct. Those are generally not linked. Injury, physical activity, a vasectomy, none of those are proven risk factors.
So what does this all mean for what actually causes testicular cancer at a cellular level?
Yeah, the exact trigger isn't known for most cases, but research points strongly towards changes in the cell's DNA, basically mistakes in the genes that control cell growth. Genes called oncogenes getting switched on, or tumor suppressor genes getting switched off. A really common finding in testicular cancer cells is having extra copies of a specific part of chromosome 12, something called I12p. Scientists are looking closely at how that contributes.
Okay, shifting gears a bit. How is this cancer actually found? You mentioned early detection is key.
Absolutely. And the good news is, most testicular cancers can be found early. Often, it's just a lump noticed by the man himself.
A lump or swelling.
Exactly. A lump or swelling in the testicle is the most common sign. Sometimes a feeling of heaviness or a dull ache in the lower belly or scrotum. Importantly, pain in the testicle itself is actually pretty rare as an early symptom.
Interesting. Any other signs?
Less common things can include breast growth or soreness, which can happen due to hormones like HCG being produced by some tumors. Or in boys, signs of early puberty from hormone-producing stromal tumors. If the cancer has spread, then symptoms depend on where it's gone, like low back pain if lymph nodes are involved, shortness of breath, or cough from lung mets, belly pain, headaches.
But crucially, many of those things aren't cancer, right?
Oh, definitely. Many non-cancerous things can cause lumps or swelling, like infections, inflammation, fluid collections called hydroceles, or varicose veins called varicocele. That's why the absolute key message is, if you notice any change, a lump, swelling, ache, anything persistent, see a doctor promptly to get it checked out. Don't guess.
Right. Always best to check. Now, what about self-exams? It's a common question, and there seems to be some nuance here.
There is. Some doctors do recommend monthly self-exams after puberty, especially for men with known risk factors like an undescended testicle or family history. It helps you get familiar with what's normal for you.
But the American Cancer Society?
Their stance is a bit different. They emphasize being aware of your body and seeing a doctor right away if you find any lump or change. But they don't have an official recommendation for regular self-exams for all men.
Why is that?
Mainly because studies haven't definitively shown that routine self-exams actually reduce the death rate from this cancer. The focus is more on awareness and quick action if something is noticed.
Okay, so awareness and prompt medical attention are the main things.
Exactly. So if someone does go to the doctor with a concern, what happens next?
Huh.
The diagnostic process usually starts with the doctor doing a physical exam, carefully feeling the testicles, the abdomen, lymph nodes. Then an ultrasound is almost always the first test ordered. It uses sound waves, it's painless, and it's really good at telling the difference between a fluid-filled cyst, which is usually benign, and a solid mass, which is more suspicious for cancer.
Makes sense. What about blood tests?
Yes, blood tests for tumor markers are very important: AFP, HCG, and LDH. If these are elevated, it strongly suggests testicular cancer. And the pattern can even help figure out the type. For instance, pure seminomas never raise AFP levels. Non-seminomas often raise AFP or HCG or both.
So the blood tests give clues too.
Big clues. But here's something fascinating and quite different from many other cancers.
Oh,
A biopsy, taking a small sample of the tumor. It's almost never done for a testicular lump before surgery
really? Why not?
because there's a risk of potentially spreading the cancer cells into the scrotum or along the biopsy path.
Ah, okay. So how do they confirm it's cancer then?
The primary diagnostic method is the surgery itself. It's called a radical inguinal orchiectomy. The surgeon makes an incision in the groin, like for a hernia repair, and removes the entire testicle along with its spermatic cord. That whole specimen is then sent to the lab for pathology.
So the surgery is both diagnosis and the first step of treatment.
Exactly,
Yeah.
for almost everyone.
Hmm.
Once a pathology confirms cancer and the type, then further tests are done for staging to see if it has spread.
Right, staging, which involves imaging tests.
Yes, things like chest x-rays, CT scans of the chest, abdomen, and pelvis, sometimes an MRI, maybe a PET scan, especially useful for seminomas, or a bone scan if needed. These all help paint a picture of exactly where the cancer is.
Okay, so once it's diagnosed and they know the type, the next step is staging. This is basically mapping out how far the cancer has spread, right? And that guides everything else.
Precisely. It's crucial for planning treatment and understanding the likely outlook or prognosis. We use the AJCC-TNM system. T relates to the tumor size and extent within the testicle. N is for spread to nearby lymph nodes. M is for metastasis or spread to distant sites. And S is for the serum tumor marker levels after the orchiectomy.
TNMS.
Got it. And the stages run from 0 up to 3. Correct. Stage 0 is CIS. Stage 1 is confined to the testicle. Stage 2 means spread to nearby abdominal lymph nodes. And Stage 3 means spread to distant lymph nodes or organs like the lungs or liver.
Okay, and treatment involves a team effort.
Absolutely. Typically, a urologist who does the surgery often works with a radiation oncologist and a medical oncologist who handles chemo. It's very much a multidisciplinary approach.
So let's talk about the main treatments. Surgery is the first one.
Yes, surgery is foundational. The radical inguinal orchiectomy we discussed is nearly always the first step. Removes the primary cancer. Depending on the type and stage, particularly for non-seminomas, a second major surgery might be needed later. That's the retroperitoneal lymph node dissection, or RPLND.
RPLND. That sounds like a big operation.
It is. It involves removing the lymph nodes at the back of the abdomen, where testicular cancer often spreads first. It's complex, takes several hours, and really should be done by surgeons with a lot of experience in it.
Are there less invasive options?
Sometimes laparoscopic RPLND is possible, using smaller incisions. Recovery can be faster. But there's still some debate about whether it's as effective as the open surgery at removing all potentially cancerous nodes, especially in more advanced cases. So that's a discussion to have with the surgeon.
Right. What about the side effects of surgery? Losing a testicle.
Losing one testicle usually doesn't cause long-term problems with erections or sex drive, as the remaining one compensates. If both have to be removed, which is rare, then yes, that causes infertility and low testosterone. Low testosterone needs lifelong hormone replacement therapy to manage symptoms like fatigue, low sex drive, muscle loss.
And body image?
That can be a concern, understandably. Testicular prostheses, basically implants, are available and can be placed during the orchiectomy or later if desired.
What about side effects from the RPLND, the lymph node surgery?
The main potential long-term issue there is retrograde ejaculation. Damage to nerves during the surgery can cause semen to go backwards into the bladder during orgasm instead of out.
Which affects fertility.
Yes, it can make natural conception difficult or impossible. However, skilled surgeons can often use nerve-sparing techniques now to preserve normal ejaculation. This is really important to assess beforehand if future fertility is a concern. Sperm banking before any treatment is also a key option.
Good point. Okay, moving on from surgery, what about radiation?
Radiation therapy uses high-energy rays to kill cancer cells. It's primarily used for seminomas, which are very sensitive to it, usually used if seminoma has spread to the nearby lymph nodes, or sometimes for treating spread to distant sites of the brain. It's less common for non-seminomas.
And side effects.
Short-term can include fatigue, nausea, diarrhea, maybe some skin redness in the treated area. They always use a shield to protect the remaining testicle to preserve fertility. A potential long-term concern is a slightly increased risk of developing a second, different cancer later in life, in or near the radiation field, though modern techniques use lower doses to minimize this.
Okay. And the third main tool is chemotherapy.
Right, chemo, using drugs to kill cancer cells throughout the body, usually given intravenously. Drugs like cisplatin, etoposide, bleomycin, often used in combination, like the common BEP regimen.
When is chemo used?
It's used when cancer has spread beyond the testicle, so stage 2 or the third, or sometimes after surgery, even in stage 1, to reduce the risk of the cancer coming back, what we call adjuvant chemo. It's not typically used if the cancer is completely confined just to the testicle.
And chemo side effects are usually pretty well known.
Yes, the common short-term ones: hair loss, mouth sores, nausea, vomiting, fatigue, increased risk of infection due to low white blood cells, easier bruising or bleeding from low platelets. Specific drugs have their own potential issues, too. Cisplatin can cause kidney damage, nerve damage called neuropathy, or hearing loss. Bleomycin can damage the lungs. Ifosfamide can irritate the bladder. Most of these get better after treatment stops, but some, like neuropathy, can linger.
Any long-term risks with chemo?
Yes, unfortunately. There's a small but serious long-term risk of developing a secondary cancer, most notably leukemia, linked particularly to drugs like etoposide. Maybe less than 1% risk, but it's there. Also, survivors treated with chemo, especially cisplatin-based, might have a higher risk later in life of heart problems, high blood pressure, or high cholesterol.
So important things to monitor long-term.
Definitely. And one more intensive option is high-dose chemotherapy with a stem cell transplant.
When would that be used?
It's generally reserved for cancers that have come back after standard chemo, or sometimes for initial treatment of very advanced, poor prognosis cases. It allows much higher chemo doses. But it's a very tough treatment with significant risks and side effects, usually done only at specialized centers.
Okay, so we have surgery, radiation, chemo. It sounds like the treatment plan is really tailored. What does this all mean for you as a patient? It's very specific, isn't it?
Absolutely. It's highly individualized based on the exact type, seminoma or non-seminoma, and the precise stage.
Can you give us a quick feel for that, like for stage 0, CIS?
For CIS found incidentally, sometimes just observation is an option. If found during an orchiectomy done for cancer, often no more treatment is needed. If found via biopsy for other reasons, treatment might be observation, surgery to remove the testicle, or sometimes low-dose radiation.
And stage I seminoma, after the orchiectomy.
For stage I seminoma, the preferred option for many experts now is actually active surveillance, or watchful waiting, just close monitoring with exams, markers, and scans.
Why? Doesn't it come back sometimes?
It does, maybe 15–20% of the time. But even if it recurs, it's still highly curable with chemo or radiation given at that point. So surveillance avoids immediate treatment side effects for the majority who are already cured by surgery alone.
That makes sense. Other options?
Yes, other options are preventative radiation to the abdominal lymph nodes, or 1 or 2 doses of chemotherapy, usually with a drug called carboplatin.
Okay. What about non-seminomas, stage 1?
For stage I non-seminomas, it's a bit more complex. Options after orchiectomy depend on risk factors for recurrence. They include surveillance. Though relapse rates are higher than for seminoma, it's still very curable if caught early. Or preventative treatment with RPL&E surgery, or 1 cycle of combination chemotherapy like BEP. The choice depends on individual factors and discussion with the oncology team.
And for more advanced stages 2 and 3?
For stages 2 and 3, meaning the cancer is spread, chemotherapy is usually the main treatment, typically multiple cycles of combination chemo like BEP or EP. Often, after chemo, surgery like RPL&D might be needed to remove any remaining lumps or masses seen on scans, especially for non-seminomas.
What if the cancer comes back? Recurrent cancer?
Recurrence usually happens within the first 2 years if it's going to. If it does, getting a second opinion at a major cancer center that specializes in testicular cancer is often recommended. Treatment then might involve different chemo drugs, possibly RPL&D if not done before, or sometimes high-dose chemo with a stem cell transplant. Even recurrent disease is often still curable. So after all that active treatment finishes, a really new phase begins: survivorship. And what's just crucial here, absolutely vital, is that follow-up care is extremely important.
Right, you can't just finish treatment and disappear. Why is follow-up so critical?
Well, two main reasons. First, if the cancer is going to come back, catching that recurrence early gives the best chance of curing it. And testicular cancer recurrences are often still very treatable.
So surveillance catches it early.
Exactly. Second, there's that small but real chance of developing a new cancer in the remaining testicle later on. Follow-up helps monitor for that too.
So what does follow-up typically involve?
It involves a regular schedule of doctor visits, physical exams, blood tests to check those tumor markers, AFP and HCG, especially for non-seminomas, and imaging tests like CT scans or chest x-rays. The schedule is usually more frequent in the first few years after treatment, when recurrence risk is highest, and then gradually becomes less frequent over time, but often continues in some form for many years.
And doctors should provide a plan for this.
Yes, ideally you should get a survivorship care plan. This summarizes your diagnosis, the treatments you received, and outlines the schedule for future tests. It should also list potential long-term side effects to watch out for, give advice on things like diet and exercise, and remind you about keeping good records and maintaining health insurance. It's like your personal health roadmap going forward.
That sounds really helpful. Now, a question survivors often have: is there anything they can do to lower the risk of the cancer coming back?
That's a common question. In terms of specific actions to prevent testicular cancer recurrence, the science isn't really clear. There aren't specific diets or supplements proven to do that. However, adopting generally healthy behaviors is always recommended for overall health and well-being. Things like not smoking, eating a balanced diet rich in fruits and vegetables, staying physically active, maintaining a healthy weight. These are good for everyone, especially cancer survivors.
So general health is key, but be wary of unproven supplements.
Definitely. Always talk to your doctor before starting any supplements, as some could even interfere with treatment or follow-up. Now, connecting this to the bigger picture for survivors, something really important to be aware of is the risk of second cancers.
Meaning, not the testicular cancer coming back, but a completely new, different cancer later on.
Exactly. While your testicular cancer might be cured, survivors do have a slightly increased risk of developing certain other cancers later in life compared to the general population.
What kinds of cancers?
Well, the most common second cancer is actually another testicular cancer in the remaining testicle. But beyond that, there can be increased risks for cancers of the rectum, pancreas, bladder, kidney, thyroid, and even a rare but increased risk of blood cancers, like acute myeloid leukemia, AML.
Wow. Is that linked to the treatments they received?
Yes, often it is. Radiation therapy, for example, increases the risk of cancers developing in or near the area that was treated, like bladder, colon, stomach cancer. This risk seems to increase starting about 5 years after radiation and might double after 10 years or more.
So the radiation itself can cause problems down the line.
It's a potential long-term effect, yes, though again, modern lower doses aim to reduce this. Chemotherapy has also been linked to slightly increased risk of kidney, thyroid, and soft tissue cancers, and that rare risk of leukemia, particularly associated with drugs like etoposide and cisplatin. Plus, as we touched on, chemo survivors might face higher risks of heart problems or high cholesterol later.
So what's the takeaway for survivors regarding these risks?
It really emphasizes the need for lifelong vigilance and regular medical care. Adhering to recommended screening guidelines for other cancers, like colorectal cancer, is important. And maintaining that healthy lifestyle, not smoking, limiting alcohol, healthy diet, exercise, can help lower the risk of some of these second cancers, too. It's about long-term health management.
And finally, dealing with cancer is obviously a huge emotional and psychological challenge.
Immense.
Yeah.
It's completely normal to feel depressed, anxious, worried, fearful about recurrence during and after treatment.
So seeking support is okay.
Absolutely essential for many people. Talk to friends, family, join a support group with other testicular cancer survivors. Sharing experiences can be incredibly helpful. Professional counselors or therapists can also provide vital coping strategies. Don't hesitate to ask your cancer care team for resources. This deep dive has really shown us the remarkable progress in treating testicular cancer. It's gone from being a very feared diagnosis to one with truly high survival rates, but also highlights that the journey doesn't just end with treatment. For survivors, there's this ongoing path of navigating potential long-term effects and the absolute importance of lifelong health awareness and management.
So thinking about everything we've discussed, what stands out most to you, the listener? Maybe it's the sheer power of early detection, how finding it early makes such a difference. Or perhaps the surprising ways different treatments can impact long-term health years down the road, or just how crucial ongoing research is for making treatments even better and kinder. Here's something to consider. With treatments constantly evolving, how might future breakthroughs continue to change things for cancer survivors? Could we see even fewer long-term side effects, more personalized approaches? It's definitely something to think about. We hope this deep dive helps you feel more informed and ultimately empowered.